Okay, I think it's time to get started. So, my name is Christoph Kiruk. I'm a nephrologist, as some of you know from the small group that I'm running. I'm interested in genetics, and today we'll discuss a group of very interesting disorders, many of them with a genetic causation, broadly termed as cystic kidney diseases. And I'll deliver this lecture with Dr. Newhouse, who will discuss some of the radiologic features of these really fascinating disorders. Broadly, cystic kidney diseases can be classified as acquired or hereditary or genetic, and we'll mostly concentrate on the genetic types, although we'll show you some of the acquired forms as well. Among the genetic forms, we selected 4 disorders that are very characteristic that I think you should be able to distinguish, and we'll discuss their clinical features. These include 2 autosomal dominant disorders that manifest in adulthood and 2 autosomal recessive disorders, which are pediatric disorders. And among these, the most common one is autosomal dominant polycystic kidney disease. It is actually one of the most common causes of genetic kidney disease, and I guarantee that regardless of your specialty, you will see some of these patients in the future. So we'll spend a lot of time discussing autosomal dominant polycystic kidney disease, but then we'll also discuss these rare recessive forms. So we'll talk a little bit about autosomal recessive polycystic kidney disease, the nephronophthisis spectrum of disorders, and then we'll go back to adult nephrology and we'll talk about medullary cystic kidney disease. But we'll start with something relatively simple. So Dr. Newhouse will show you some really interesting images here.
Okay. Morning all, and hello again. Simple renal cysts. You see this picture? You did not see it in the classification of diseases. It is here not because it is a public health problem. What you're looking at here is a condition which does not make anybody sick. And it's not here because it is a genetic problem. As far as we know, there is no particular inherited tendency to get these. It's here because this is by far the commonest kind of kidney cystic abnormality that you will encounter if you practice any kind of adult medicine at all. Simple renal cysts appear in increasing prevalence as people increase in age. You get to the point where people half a century old, the chances that they've got this disease are approximately equivalent to their age in percentages. I got a bunch. I got a CT a little while ago, and I have a bunch of them. I would show you my own, except they're not as pretty as these. Cysts look just like what you might expect them to. They are sort of membrane-surrounded spherical bags of fluid. This is a CT. We talked about how we did CTs a little while ago, and here's a medium-large one sitting on erupting from a kidney. Another picture from a CT in another patient. Here's a small one. These things start absolutely microscopically, of course, and just get bigger. Here is an ultrasound image. There is somebody's right kidney, and sitting in the middle of it is this echo-free bag of water. To repeat, they are common, but it is almost unheard of for anybody to have symptoms from them, almost unheard of for anybody to have any chemical complications from them. So what should you do about them? Know they exist, be not surprised when you run into them, and don't worry about them.
Thank you.
There you go.
Okay, here we go. So there's another example of a simple cyst on a CT scan. But you can also see, there's also a number of cysts on the other side. Let me just point it out here. And what do you do? What do you see here? What's wrong with these kidneys? They're kind of shrunken, small kidneys, right? So actually, the cysts, the risk for developing cysts increases as in end-stage renal disease. So these are actually end-stage renal disease kidneys that are small and shrunken, and you can see some of them can contain multiple cysts. So this is not an uncommon finding in patients on dialysis, and this is not much to worry about, except perhaps that in severe forms of this cystic kidney disease, there might be an increased risk of malignancy. So occasionally you have to think about malignancy, especially if the patient has other symptoms. So I think a nice way to illustrate some of these genetic disorders would be to go over some of the common presentations of these diseases. So I prepared 4 cases, and we'll go over this. They're very brief cases, but I think nicely illustrate common clinical features. So let's start with case 1. So this is a case of a 30-year-old healthy man who is playing basketball, and he's being elbowed in the flank during a pickup basketball game and develops severe colicky abdominal pain. And after this, develops basically red urine. Red urine is something that really brings the patient to an attention of a physician, right? So it's a very concerning type of symptom. So he comes to the emergency room. His blood pressure is high. It's 160/100. His creatinine is normal at 0.9. He's hospitalized, and a renal ultrasound is performed. So we'll ask Dr. Newhouse to interpret the radiology findings.
Well, you're now pros at looking at renal ultrasounds. You've seen 3 or 4. These are images of this patient's kidneys, one on one side, one on the other, and you see a bunch of black holes in the middle of them, which are bags of water like the others. The things that are different about these, compared to the ones that you saw before, is that the more you stare at these, the more you see. It's like counting stars. There are big ones, little ones. There's very little by way of normal kidney tissue interspersed among these. So unlike the simple cysts, which displace normal kidney but don't do much to it, here these cysts are so numerous, so large, grow so much that they very much do interfere with kidney function and lead to the manifestations of this disease, which is autosomal dominant polycystic kidney disease, that you're about to hear in more detail.
Just one more second. A little bit more imaging.
Okay, smart. Same disease. CT, you're now used to looking at CTs. Bags of water of various sizes in the kidneys. Again, notice, less and less normal kidney in between the cysts. This is an MRI. Once more, don't worry about how one makes MRI images. Simply to say that one of the ways that you can do it is a technique in which anything in which there is stationary fluid looks very bright and all the rest of everybody's anatomy just disappears. So going from the bottom up, here's this patient's bladder, and here are this patient's kidneys, and it's just chock full, nearly replaced by these bags of water with less and less normal parenchyma in between. Switching over to this top left one now as the last one of the things that goes along with this disease is that there, in most patients, turn out to be hepatic cysts as well. So there's a liver cyst, there's a liver cyst. They are eye-catching. They help very much in making the diagnosis of the disease. They're of clinical importance, however, in only a small fraction of these patients. Patients inevitably get into kidney trouble and only rarely get into clinical hepatic trouble from this condition.
Excellent. So based on this imaging, basically the diagnosis of autosomal dominant polycystic kidney disease can be established. This imaging is diagnostic. This particular patient was treated with analgesics and fluids. The pain subsided. The gross hematuria resolved within 4 days. Sometimes it takes a while for the episodes of gross hematuria to resolve. So you basically hydrate the patient, you treat the pain, and you wait. Most of the time, they do not require transfusions. The bleeding is not really life-threatening, but it could cause complications. You know, if clots form, for example, they could obstruct and cause post-obstructive renal failure. So you have to be aware of this. So this patient was discharged home. So let's talk a little bit about the genetics and the epidemiology of this disease. So this, as I mentioned, is the most common form of inherited kidney disease, with frequency of this defect of 1 in 500 to 1 in 1,000. So it really, I can assure you, you will see some of the autosomal dominant polycystic kidney patients in the future. The disease manifests in adulthood, usually in the 3rd, 4th, or 5th decade of life. And it does have autosomal dominant inheritance, although the penetrance is incomplete. And because there's incomplete penetrance, that means that people who carry the mutations might not express the full phenotype. Family history is not infrequently negative. In fact, the family history is positive in only about 60% of the cases. And nearly 50% of, as a kind of rule of thumb, about 50% of patients reach end-stage renal disease before the age of 60. Of course, some of them could die of, or have other diseases die of other causes earlier, and in those individuals, the disease will never be diagnosed. The genetics of autosomal dominant polycystic kidney disease is very interesting. There are two genes that are responsible for the great majority of cases. These genes are polycystin PKD1 and PKD2. These two genes encode proteins called polycystins, polycystin-1 and polycystin-2 respectively. And it turns out that homozygosity for these genes, so homozygosity for the mutations in these genes, are lethal. So basically, there are no people that inherit both kind of mutant alleles from both of their parents. Basically, these kids do not get basically carried to term. Heterozygotes, however, develop this second hit mutation at the somatic, at the tissue level in the kidney. So this process perhaps explains the incomplete penetrance of the disease. There's one inherited allele from the parent, and then there's a second somatic mutation that takes place randomly at the tissue level that leads to basically a tissue homozygosity or tissue loss, loss of normal function, complete loss of normal function of these proteins. And this kind of explains the autosomal dominant inheritance pattern. So it's not classic autosomal dominant. It's a little bit more complicated. And to make it even more complicated, transheterozygotes for these mutations, so individuals that develop one mutation in that inherit one mutation in PKD1 and another mutation in PKD2, have much more severe clinical course, which is what you would expect under this model as well. These are the structures of polycystins, the two proteins that are implicated in this disease. As you can see, polycystin-1 is a very large protein with multiple transmembrane domains, a large extracellular portion here, and also a large intracellular portion. The polycystin-2, in contrast, is a much smaller protein. It actually is a calcium channel. So it forms a channel. It has both the carboxy and N-terminus are intracellular. And mutations in polycystin-1 account for about 85% of all cases of autosomal dominant polycystic kidney disease. So this is the protein that's dysfunctional in most of the cases. In contrast, mutations in polycystin-2 and PKD2 account for about 15% of the cases. And so what do these polycystins do? It turns out that they actually form a complex. So they actually complex, the C-termini of these proteins interact, and they form a complex at the cell membrane. And where are they expressed? Well, it turns out they're expressed at this ciliary structure, specifically at primary cilia. So this is just for your review. There are different types of cilia in the body. There are motile cilia that line the respiratory epithelium, ependymal cells, fallopian tubes, and also they're present in the sperm. So these are the cilia that can move fluids or propel sperms, for example. There are also sensory cilia, which are present in the inner ear cells, as you learned previously from lectures on diuretics, actually, yesterday, and also retinal photoreceptor cells, where cilia actually form a scaffold for retinal photoreceptor cells, and they're really important in light perception. And finally, there are primary cilia, which are practically present in all of the epithelial cells in the body. This includes, of course, renal epithelium, but also bile duct epithelium, pancreatic duct, and any other epithelial structure. Usually there's one single cilium per cell. This is actually a scanning electron micrograph of a collecting duct. And what you can see here, these are principal cells. Do you guys know what this is? Just knowing about the composition of the collecting duct. This is actually an intercalated cell, okay? But you can see that each of the cells has a little cilium projecting from the center. So this is just to emphasize that they're present in a collecting duct where they play important functions. So polycystins are actually expressed very specifically within the cilia. So this is immunofluorescence for polycystin 2 and polycystin 1, both indicated in green. And alpha-tubulin here is in red. And you can see that polycystin 2 very nicely colocalizes with alpha-tubulin, really indicated very specific expression of this protein in the cilia. And then, again, polycystin 1 in green and polycystin 2 in red colocalize very nicely in the cilium. So what do these proteins do in the cilium? Well, there are several hypotheses, and this is still not completely resolved in the polycystic kidney disease research community. But one hypothesis is that cilia are essential for sensing of urinary flow in a collecting duct. So how does it work? So remember, polycystin 1 is this large protein with very large extracellular portion, and that extracellular portion is projecting from the cilium, and it's implicated that it's sensing the flow of the urine. It is also coupled to the calcium channel polycystin 2. When there is a flow of urine and stress on the extracellular portion of PC1, that leads to opening of polycystin 2 calcium channel and leads to an influx of calcium into the cell. And that triggers then a number of processes that lead to further release of calcium from intracellular stores and subcellular activity. So this is one hypothesis, that perhaps there's a defect in flow sensing in the collecting duct that leads to the development of cyst. Another hypothesis, and perhaps these are not mutually exclusive, perhaps there's a relationship between these hypotheses, is that of disrupted planar polarity. So it is known that when the cells divide in a tubular structure, the mitotic spindles of the cells are usually aligned parallel to the axis of the tubule. And that leads to gradual elongation of the tubular structure, epithelial tubular structure. Well, it turns out that in polycystic kidney disease, when you look at the tubules and when you look at the cell divisions within the tubules, the mitotic spindles are randomized, meaning they're not aligned parallel to the tubular structure. They can be perpendicular or at any other angle. And so when you have disoriented cell division like this really leads to basically increasing diameter of the tubule as opposed to elongation. And this is one potential explanation why the cyst might be formed. And perhaps the flow sensing of the primary cilium is essential for proper alignment of the mitotic spindles. Although there are other mechanisms that are postulated in this process, and it's probably much more complex than just simple flow sensing mechanism. But these are two general hypotheses about the development of cysts that are being studied very actively. So how do we put it together? So let's just summarize the model of cyst formation in this really interesting disease. So first, there's a genetic risk, inherited risk. So basically, you inherit a single disease allele, a mutation in PKD1 or PKD2. Then there's a second hit. There's a somatic mutation at the tissue level, which knocks out the other copy of the gene, leading to basically a kind of homozygous tissue effect. And that inactivates polycystin signaling. And then with time, this leads to cystogenesis. So there's disrupted planar polarity, so there's defect in cell division. There's also an increased rate of epithelial proliferation, an increased rate of fluid secretion into the cysts. And this basically leads to increased diameter of the tubules, and these outpouchings of the tubules that are due to increased proliferation. With time, these will actually form pockets and then independent benign tumors, cystic tumors, that will continue to secrete fluid inside of the cyst. And as this process continues throughout life, this is a slow, progressive type situation. The cysts will gradually fill out the entire renal parenchyma and will lead to major distortion of the kidney architecture. So let's discuss common clinical complications of this process. This is a picture of kind of end-stage polycystic kidney disease. You can see that practically the entire renal parenchyma is destroyed by these cysts. So there's no more differentiation between cortex and medulla, right? The medulla is destroyed. Basically, the complications that you frequently observe clinically are related to the fact that the architecture is gone. So first, one of the earliest manifestations is actually elevated blood pressure. And this is typically due to elevated renin release. And it might be related to disturbed architecture again and disturbed sensing of the renin-secreting cells of the flow in the distal tubules or in a distal nephron. So this is usually high renin hypertension is pretty much present in all of these patients. The second common complication is flank or abdominal pain. And this is simply by compression of the stretching of the renal capsule and also compression of other organs in the abdomen by really massively enlarged kidneys. Macroscopic hematuria, like in a case we discussed, is also very common. That's due to cyst hemorrhage, and contact sports are usually a very common trigger to this or any other kind of injury to the kidney. Fever and abdominal pain are usually symptoms of cyst infection, and we'll discuss a little bit more on this topic. Kidney stones are also common, and this is due to stagnant urinary flow, and I think we have the entire lecture on kidney stones later today. So you'll learn more about stones. And then you get other complications just of dysfunctional tubules. So low-level, low-grade proteinuria, polyuria. So remember, your concentrating gradient in the medulla is required to concentrate urine. That whole medullary architecture is destroyed, so you won't be able to concentrate urine. And then, of course, with time, you have progressive decline in GFR. And as I mentioned before, about 50% of patients reach end-stage renal disease by age 60, commonly requiring dialysis or transplantation. But there are also extrarenal manifestations, and we already picked up one on the CT scan. That is, there are cysts in other organs. So this is an example of an autopsy specimen from a patient with the disease showing large cysts in the liver. Hepatic cysts are probably the most common extrarenal manifestations. They're present in about 80% of cases, and they affect women more than men for unclear reasons. Okay? There are other extrarenal complications. For example, heart defects are not uncommon in this population, especially mitral valve prolapse and PFOs. There are also colonic diverticula, subcutaneous, ovarian, testicular, pancreatic, pulmonary cysts. So basically, there's propensity to form cysts in other organs. And finally, one complication that you should keep in mind is there's an increased risk of cerebral aneurysms. So what are cerebral aneurysms? These are basically defects in the vasculature, in the cerebral vasculature, and they're relatively rare in general, and even within the population of patients with polycystic kidney disease, estimated to about 5 to 8% of cases. But they're important because they're potentially lethal. So the aneurysms, as they enlarge with age, they can rupture. And when an aneurysm ruptures, it leads to very serious complications, subarachnoid hemorrhage, coma, and death. So the question commonly asked by people who take care of these patients is, well, how do we screen for this? This is, the prevalence of this is 5 to 8%. Do we need to, is it cost effective to do head scans, MRAs in these patients? And the answer is, if there is no family history of head bleeds or cerebral aneurysms, and there's absolutely no symptoms that would suggest that an aneurysm is present, you probably don't need to do an MRI to basically screen for the presence of aneurysms. However, in the presence of positive family history, or if a patient with polycystic kidney disease presents to you with severe headache, this is something that's really on the top of your list to consider. And so the family history effect is interesting, suggesting that there are additional genetic factors that probably predispose these patients to develop cerebral aneurysms. And of course, the treatment options for this, electively, you could treat it by basically occluding it by doing coiling, which is an intravascular procedure performed by interventional radiologists, or you could do an open procedure where you can basically clip it off surgically. How do we make the diagnosis? So we always ask about family history of this disease, even though it's negative in 40% of the cases. Certainly if it's positive, it's extremely helpful. And imaging studies. And so renal ultrasound reliably detects cysts that are greater than 1 centimeter in size. And Dr. Newhouse told me recently that actually the renal ultrasound, the resolution is getting so good that you can pick up much smaller cysts. And so in the past, there was this set of diagnostic criteria based on renal ultrasound called Ravine criteria, which basically took an age-specific cutoff for the presence of the number of cysts visible on ultrasound to diagnose the disease. But it's probably now a little bit outdated because our ultrasound has gotten so much better that we are actually picking up even much smaller cysts. So probably there's no good criteria for you to remember here, but remember that if you have positive family history and multiple cysts in the kidneys, that is usually sufficient to make the diagnosis. So let's look at some of the late complications of this disease. So this is a second case, also with autosomal dominant polycystic kidney disease, but this patient now has end-stage renal disease. He has been on dialysis for the past 2 years and presents to you with abdominal pain and new umbilical hernia. He continues to produce small amounts of urine, but the volume has decreased substantially over the last few months. And the other recent elements of the history include recurrent kidney stones, intermittent hematuria, 2 severe kidney infections, and chronic lower back pain and flank pain, so consistent with the complications that I've already described. This is the patient. You can clearly see umbilical hernia. And this is the image of the patient. It's pretty obvious. I don't think we need Dr. Newhouse to interpret these images. Like very impressive cystic structures filling out practically the entire abdominal cavity bilaterally. You can see compression of the abdominal organs, and of course this patient is very symptomatic. So he has end-stage renal disease, the kidneys are already not working, probably it's time to get rid of them. So in this setting, the patient was scheduled for bilateral nephrectomy, and this is what you see when you do the bilateral nephrectomy. Really impressive, nasty-looking cystic kidneys. So let's talk about the treatment of complications. So hypertension, as I mentioned, is a very common complication. It's driven by high renin state. So typically we treat it with self-restriction and, of course, ACE inhibition or ARB as kind of a first-line treatment. And it turns out that these medications actually help to preserve renal function as well. So hypertension might propel the progression of the disease by adding this extra injury, vascular injury, to the process, the disease, the primary disease process. In terms of hematuria, it's frequently due to either intraparenchymal hemorrhage or cyst hemorrhage. We treat it, as I mentioned before, with bed rest and analgesia. We provide hydration to increase urinary flow up to 2 to 3 liters per day, and this is simply to prevent obstruction, because if you have concentrated urine, it is more prone to form clots and cause obstruction. So that's the thinking behind increasing urinary flow. In terms of cyst infections, these usually require hospital admission and IV antibiotics, and one of the problems is that cyst infections are difficult to treat because the penetration of the antibiotics is limited into that space. So it's pretty much an enclosed abscess type situation, and the entire cysts can, become kind of filled with pus. The first-line antibiotic that we use for the treatment of cyst infection is fluoroquinolone. It has good intracyst penetration compared to the other antibiotics, but again, this is a fairly serious situation for which you will probably need to admit the patient. And renal stones, basically the treatment is no different from renal stone of other causes, so I'm not going to talk more about this. You'll hear about this at the next lecture. And finally, flank pain for acute pain, usually you need to worry about a more acute process, so you need to worry about potential renal infection, cyst hemorrhage, or perhaps a renal stone that's causing obstruction. For chronic pain is very common and usually occurs due to distension of the kidney capsule and compression of abdominal structures. And you have to kind of treat it just conservatively with pain medications in these patients. If it's extremely severe and the kidneys are near end stage, then you can consider nephrectomy. And this is typically the type of progression that we observe in this disease. Early on, you observe hypertension, tubular level proteinuria, so subnephrotic proteinuria, a concentrating defect due to disrupted kidney architecture, and with time you develop these late complications such as increasing pain, perhaps gross hematuria, kidney stones, and infections. And you can see that in the kind of early 50s and late 50s and early 60s, typically the renal function starts to decline, and a lot of patients reach end-stage renal disease by the age of 60. What is interesting is that the severity of the disease caused by mutation in polycystin-1 versus polycystin-2 are slightly different. So polycystin-1, remember, that's the large protein, that's the flow sensor. These mutations tend to be much more severe, so they lead to an earlier disease and a faster progression to end-stage renal disease in comparison to patients that carry mutations in polycystin-2 or PKD2. So you can see this is renal survival percent of patients that are end-stage renal disease free. And you can see that most of the patients with PKD1 mutation develop end-stage renal disease between the ages of 40 to 60, and PKD2 after the age of 60. They're also diagnosed earlier. This is another interesting figure that's basically this is a larger study of a cohort of patients with polycystic kidney disease that are being followed longitudinally. And what's examined here is the kidney volume or kidney size as determined by imaging techniques. And each patient here is indicated by a line, so the first dot represents the first measurement of kidney volume, and then there's subsequent measurements of kidney volume. And you can see dependence on age. Red and blue indicates males and females. There's not much difference by sex here. But what you can really readily see is that patients that start with a much higher total kidney volume progress much faster. So there's almost this exponential growth of cystic structures in this disease. So kidney volume is a risk factor for end-stage renal disease. People who start at a much higher kidney cyst volume or total kidney volume progress much faster, much more rapidly. And this is independent of sex and independent of age. Although you can see probably in this figure also that definitely with age you get more progression as well. So let's switch gears now. We'll move to a pediatric case, so a completely different disease. And let me read through this case. So we have a 7-year-old girl who is brought to the emergency room after vomiting blood. On exam, she exhibits jaundice. She has palpable hepatosplenomegaly. Lab evaluation reveals severe anemia, thrombocytopenia, elevated creatinine, low albumin, and elevated liver enzymes. So really a lot of abnormalities frequently seen in liver failure, but she clearly has renal failure as well. And then there's another piece of information here. Older sister died shortly after birth with Potter sequence. Do you guys know what Potter sequence is? Anyone? No? Okay. So I guess I'm the only one that discusses Potter sequence in this lecture. It's basically the syndrome that's seen when kidneys fail in utero. Okay? So it's a complete renal failure in utero. And it's called a sequence because it has a number of dysmorphologic features that are readily apparent. So these pictures demonstrate the features. So what happens when kidney fails in a fetus? Well, it turns out that renal function is really essential to generate amniotic fluid. And so it leads to a decreased volume of amniotic fluid, a condition that we called oligohydramnios. And that has consequences. So when there's decreased amniotic fluid, the fetus gets compressed against uterine walls, and this leads to characteristic facial features which are simply a consequence of the compression of the fetus. It can also lead to growth retardation of the fetus, and worst of all, amniotic fluid is really essential for the proper development of a lung in a child. So if there's a kidney failure in utero, when that child is born, they don't only have dysmorphia and, they're small, the infant is small, but they can't breathe. And the most common cause of death is actually due to hypoxia and underdeveloped lung. So very serious condition. And some of the dysmorphology here, characteristic flattened nose and infraorbital creases are very characteristic in this particular syndrome. So it turns out that the parents of this child came from Saudi Arabia, and this is the family tree. The older brother of the index case, this is the index case, always indicated by an arrow. This is the older brother. Older brother is healthy, and I mentioned sister was born with Potter syndrome and died of hypoxia shortly after birth. What is this pedigree consistent with in terms of inheritance pattern? Autosomal recessive, very good. And why do you say that? Right, so there's a clear consanguinity loop here, right? So the parents are actually first cousins. And so remember that in some parts of the world, these are not uncommon situations. And Saudi Arabia is one of them. Turkey is another one. The Middle East, it's a very common situation that there are marriages among closely related individuals. And the prevalence of recessive disorders is increased in these countries. And of course, here living in New York, we see these patients coming in for consultations from Saudi Arabia and other places. So this is a real case that we consulted on. And here we have the imaging.
Well, what we have here on your left is an ultrasound of one of this patient's kidneys. The other looked exactly the same, and on your right, ultrasound picture of the liver. Now, by this time, you've learned enough about renal cysts to be able to recognize them. In this kidney, there are several tiny little ones, but they are quite small, and most of the rest of the kidney volume is not taken up by cysts at all, but something else is wrong with it. Don't know if you remember some of the ones you've seen before, but if you look at all the rest of this kidney substance in here, it is much lighter, much brighter, many, many more little white speckles making it up than were in the normal case. What's going on here essentially is this. This is a polycystic kidney disease as well, but the pathology is different from that of autosomal dominant polycystic kidney disease. You've seen autosomal dominant ones. If you see it in a late stage and you cut it open with a bread knife, it just looks like a gigantic sponge full of big holes. In these kidneys, you may see little cysts, but mostly what happens if you cut it open with a bread knife is that you can't really see very many large cysts. But if you look at it with, let's say, a microscope, you don't need a microscope, just a magnifying glass, you see infinite number of tiny little cystic things, most of which are dilated tubules. Ultrasound is good, but not big and not good enough yet to show individual tubules and their dilatation. What we see instead are the white speckles that come back because of abnormal echoes coming back from these tubular walls. So in this case, although there are cysts, the major thing to notice is that the entirety of the kidney is abnormal in a way that shows multiple cysts too small to see and dilated tubules. A number of things go wrong with the liver in this case. It's not quite the same thing as an autosomal dominant polycystic kidney disease. You notice that there are a couple of little cysts here, but there's not much else that you can see in this liver. It should be okay. In this disease, there's different liver pathology, however. These people get progressive periportal fibrosis, and the more the fibrosis compresses the portal triads, the more obstruction to blood flow they have. They not only get, therefore, an abnormality of hepatic function, but they get portal hypertension. The portal blood flow cannot get through the liver very well. the pressure in the portal system rises, they get varices, they rupture, they bleed. Essentially, the sad thing about these poor patients is that if the kidney function lets you live long enough, i.e. later in childhood, not very much to adulthood, the progressive hepatic abnormalities usually do you in. So, similar sounding name, very different series of manifestations of hepatic function and kidney function, as you can see by the ultrasound images here. Yep. Oh, yep, forgot this one. This is a disease which doesn't only appear postpartum, but patients have manifestations of it in utero. As you can see, this is not the same patient that you saw, but this is a typical one. If you're sitting here wondering what in the world this image is, it is an image of a pregnant woman, and it is almost a sagittal image, as if the woman were sort of cut in half here, two parts spread apart, and you looked at one cut edge. So it's as if the woman is standing and facing to your left. So there's her bladder. That's her umbilicus, her navel right there. Her spine is back here, and this whole thing is her gravid uterus. In it is a placenta. It's a normal-looking placenta. Some amniotic fluid, that bright stuff, although not as much as a normal pregnancy would have. And we have made an image of part of this fetus's anatomy here. This is an image smack through the fetus's trunk. Yes, the patient has arms, legs, head, etc. They're just not in this picture. So essentially, this is the top, this is the bottom, here's the diaphragm, the abdomen's down here, the lungs are up here, and these things are kidneys. Now, I know this is the first MRI of a fetus that you have ever seen, but take my word for it, these kidneys are way too big and way too bright. Bright because the tubules are dilated, filled with fluid, and you remember here fluid looks bright. So those kidneys are distinctly abnormal and permit a specific diagnosis before birth.
So, of course, this is autosomal recessive polycystic kidney disease. Classic imaging findings, classic history. This is an important childhood nephropathy, although it is a rare condition, right? So 1 in 20,000 live births. That's getting to the very rare disease spectrum here. Affected children often present in utero with enlarged echogenic kidneys, as you've seen, oligohydramnios, secondary to poor urine output. Approximately 30% of the affected neonates die shortly after birth, basically as a result of severe pulmonary hypoplasia and respiratory failure. Those who do survive this immediate postnatal period have usually symptoms of progressive renal disease and also liver fibrosis. So they develop systemic hypertension and portal hypertension. And these are, this is a molecular defect in this disease. So they're actually a damaging mutation in a protein called fibrocystin. Fibrocystin is another large protein that is present in the cilia. And this time, fibrocystin seems to be important for the normal function of the collecting ducts, but also the biliary structures. So this explains why these kids develop both hepatic manifestations of the disease, liver fibrosis, and renal manifestations of the disease with polycystic kidneys, echogenic kidneys, and progressive renal insufficiency. All right, we'll move on to another pediatric case, a brief case. This is an 8-year-old boy who is brought by his parents for evaluation of frequent urination, which is basically he has polyuria. He urinates at night. He's wetting his bed. On exam, his blood pressure is normal. He has short stature for his age. His blood tests reveal anemia and creatinine of 2.5. Now think about a little child, a little boy, 8-year-old boy. Creatinine of 2.5 is enormous, right? So this is an advanced renal insufficiency. Of course, remember, creatinine level is proportional to the muscle mass, right? LFTs are normal. His urine has low specific gravity. That means he's not concentrating his urine, right? But no proteinuria and no hematuria. And renal ultrasound confirms kidneys that are normal for his age in terms of the size, but there's increased echogenicity and loss of corticomedullary differentiation, but no visible cysts. So what do you guys think should be the next step in establishing this diagnosis? We have the ultrasound, which is not that helpful. It's definitely not autosomal recessive polycystic kidney disease. There are no cysts on the ultrasound. It's not dominant disease. What would you like to do? Biopsy, very good. So renal biopsy was performed. And what do you see here on the biopsy images? So I think what's really striking is that there's a great degree of renal fibrosis, as you can see in the upper image. Right, so all of the tubules are really separated by tremendous degree of fibrosis. And the tubules are not quite normal. They're distended. In some areas, they form these microcysts. And these are basically too small to be detected by renal ultrasound. They do contribute to increased echogenicity of the kidney, as is fibrosis, but they're too small to really be seen by ultrasound. So ultrasound typically does not depict cysts unless the disease is really late in its stage. So this type of biopsy, in combination with this presentation in a fairly young child, is very characteristic of another spectrum of conditions called nephronophthisis. So let me tell you about the clinical features of nephronophthisis. It is the most frequent genetic cause of end-stage renal disease in children. It affects children at the median age of 13. Initial symptoms are mild. They start approximately at the age of 6. They consist of polyuria, polydipsia, secondary enuresis, and anemia. These are symptoms, classic symptoms of renal failure in kids. Because the kids are peeing a lot, they're not able to concentrate urine, they also drink a lot. So characteristically, they're thirsty at night, they want to drink. Renal ultrasound is useful only in advanced disease, otherwise it will just show increased echogenicity. Only in advanced disease, cysts are visible. And renal histology shows this triad of corticomedullary cysts, which are not, again, too small to be detected by radiology. Tubular disruption, tubular abnormalities. The tubular basement membrane is also disrupted here and markedly thickened. So that's another characteristic feature. And marked tubular interstitial fibrosis. And what's really interesting is that this disorder also has extrarenal manifestations. The most common manifestations are in the eye. There is, and I'll show you a picture of this, a condition called retinitis pigmentosa. And remember when I told you about different parts of the body where you can find cilia? Well, retinal cells are one of them. So you should get a clue that perhaps this is also a ciliary disorder that affects retinal cells as well as kidney cells. Other manifestations include brain problems, so typically cerebellar problems, and we call it Joubert syndrome in combination with renal failure, and of course liver fibrosis, as in the prior case. So this is a picture of a normal fundus here in panel A. You can see normal retina, and this is retinitis pigmentosa. You see marked abnormalities in the retinal cells, leading to these dark spots throughout the fundus. And as I mentioned, the retinitis pigmentosa accompanies nephronophthisis disorders in up to 15% of cases and can be very severe, can lead to early blindness. So it's a syndrome that you need to keep in mind, blindness with renal failure in pediatric patient. Think about nephronophthisis. This syndrome has also a name, senior Loken syndrome. You probably don't need to remember that name, but think about the constellation of symptoms. It turns out nephronophthisis is also a genetic disorder. It's extremely complex. It's both genetically heterogeneous, meaning there are multiple genes that have been discovered to account for this phenotype. And the mutations have pleiotropic effects. So each mutation can cause a variety of different specific extrarenal manifestations, in addition to the common renal phenotype, which is that of nephronophthisis and renal failure. And it turns out this pie chart is a little bit outdated. perhaps 5 years old, that shows among all of the families with clinical diagnosis of nephronophthisis, how many families actually have the molecular diagnosis. You can see that a minority, probably less than 1/3, are solved. So there are a lot of families and a lot of causes of these disorders that are still unknown. Out of the ones that are solved, there are 9 nephronophthisis genes here in this slide. The first one that has been discovered, which is nephrocysteine-1, accounts for a majority of cases with known molecular background. And no surprise, all of these genes are expressed in the cilium, and they play a role in ciliary function. And then finally, this is a very active area of research right now, because we now have, in genetics, we now have technology to do genome sequencing, exome sequencing, and detect mutations in affected families more readily. So I would say that every year we have 2 additional nephronophthisis genes that are being discovered by the research community. And it's a fantastic area of research. If you guys are interested to learn more about this, we can talk after the lecture. Okay, moving on. In the last 5 minutes, we kind of move back to adult nephrology. This is actually a case that I saw as a renal fellow here in the hospital. It's a 36-year-old man who was found to have severe renal insufficiency. Basically, on routine lab check, he had creatinine of 3.1. He feels well. He has no other medical problems, except for intermittent gout attacks, which are fairly unusual for a 36-year-old. He had a renal ultrasound, which confirmed normal-sized kidneys, but there was increased echogenicity, as you might expect, with creatinine of 3.1, no hydronephrosis, and no visible cysts. So, of course, this type of a patient we want to biopsy, similar to the pediatric patient. It's an unknown etiology of renal failure. And so we did a biopsy, and it turns out that the findings are identical to the nephronophthisis patient. So he also has severe chronic interstitial nephritis, tubular atrophy, and corticomedullary microcysts. And we then get more family history on this patient, and it turns out that the patient's grandmother died of a kidney problem. You can see here. The patient's father suffers from severe gout, and his older brother also has been diagnosed with renal insufficiency and gout. So what kind of pattern of inheritance is this? Recessive dominant? Dominant, right? So it clearly looks dominant. It looks highly penetrant, right? The disease is present in each generation. So this is a classic presentation and family history for a medullary cystic kidney disease, or MCKD. That disease is pathologically indistinguishable from nephronophthisis, but it's of adult onset. This is an adult type disease, and it has autosomal dominant mode of inheritance, unlike the pediatric cases, which are recessive. Renal manifestations are basically very similar to this pediatric case that I described. So there's impaired ability to concentrate urine, polyuria, minimal proteinuria, typically no hematuria, and renal ultrasound is just showing small echogenic kidneys, no visible cysts. And there are these extrarenal manifestations characteristic for this disease, which are hyperuricemia and gout. And this is due to damage of the collecting duct structure, which, collecting duct regulates your urate clearance. So this disorder is also, there's also genetic heterogeneity, but unlike in nephronophthisis, there are just 2 genes described to date. One of them actually has been described very recently, but the first one, so there's MCKD1 and MCKD2 locus, and the molecular basis of the disease has been first described in MCKD2 type disease. So let me tell you what the molecular defect is. The mutation here is in the gene called UMOD, and UMOD encodes a protein called uromodulin. Have you guys heard of uromodulin at all? Uromodulin is also known as Tom Horsfall protein. Does this ring a bell? It's actually, so we typically say that kidneys, there are no proteins in the urine. It's not entirely, in a normal kidney, it's not entirely true. Tom Horsfall protein, or uromodulin, is one of these proteins that actually is being synthesized by kidney cells and secreted into the urine. And the function of this protein is not quite known, but it might have antimicrobial properties, so it might defend against urinary infections. It could also potentially act as an inhibitor of stone formation, but it's not entirely clear what it does. Well, it turns out if you have a mutation in the gene encoding this protein, the protein misfolds within the collecting duct cells, and it gets stuck within the cells, and it leads to tubular toxicity. And as a result of this, and you can see it here, where abnormal uromodulin is trapped within the collecting ducts and causes cell toxicity. And as a result of this, this actually triggers this inflammatory response and chronic interstitial nephritis. What's also interesting is that there are common variants in this gene that have been described in genome-wide association studies that actually predispose to chronic kidney disease in general population. These genetic variants are different from the ones that cause medullary cystic kidney disease. They actually are common, and they increase the level of secretion of this protein. So it seems like too much of this protein in the urine is actually harmful. And there's another big multi-center genome-wide association study that showed an association of this locus with increased risk of hypertension. So clearly this is a protein that we're now learning much more about, and I think there's some really interesting questions about what it actually does in the urine, and why would an excess of this protein increase the risk of kidney disease. And the last mutation I want to discuss is the one that has been described very recently and also causes practically an identical syndrome of medullary cystic kidney disease, and that mutation is actually in a gene called mucin. So mucins are also proteins that are being synthesized by tubular cells. As you can see here, they're predominantly expressed in the collecting ducts. And again, when this particular mutation in mucin occurs, the protein actually gets trapped within the cell, and it's not being expressed properly at the apical surface of the collecting duct. So you can see in normal individuals, this protein is expressed right at the apical surface of the collecting duct cells. And here, this protein indicated in green is trapped in a granule pattern within the cytoplasm. Some of it gets expressed at the apical surface, and it co-expresses with normal. Remember, this is an autosomal dominant disorder, so here you have both normal and abnormal protein expressed. So there's some colocalization of normal and abnormal, but generally there's abnormal trapping in the cells. And the mechanism of toxicity of this trapping is still unknown, but the end result is the same. These patients develop interstitial fibrosis and progressive renal insufficiency. I summarized these disorders for you in the syllabus, so I'm not going to go over this. I just included this table to tell you that there's much more to this story than what we covered. There are multiple genes that cause very similar disorders in the nephronophthisis spectrum or cystic kidney disease spectrums. Multiple rare syndromes have been described, and I think one common feature that is being shared by all of these syndromes is the fact that a lot of defective genes and defective proteins are essential for proper ciliary function. So I think I want you to remember this. And the common term for all of these diseases, the modern common term is ciliopathies. Okay, so all of these diseases that we discussed fall within this ciliopathy spectrum. The exact relationship of medullary cystic kidney disease to ciliary function is not well established, but there's a lot of research in this area as well. And I end with this beautiful image from a review article from New England Journal of Medicine from a couple of years ago that shows this nice complex structure of a cilium. It's an incredibly complex organelle that is essential for proper functioning of the kidney. And I think what I try to convince you is that ciliary defect kind of provides a unifying pathogenic link in many of the diseases of the kidneys that are inherited. And also this ciliary hypothesis of ciliary defects explains a lot of the pleiotropic effects of single gene mutations. And of course, it provides a great pathway for future research of these disorders. And as I said, there are a lot of disorders that we still don't know the molecular basis of. So I'm going to end here. We're running a little bit late, so I'll take questions perhaps after the class. Thanks. Yeah.
Quick question.
Sure.
Cells with the 2 hits,
Yes.
what's causing them to proliferate more, as in a cancer?
Yeah, so I mean, it's somewhat similar to a cancer hypothesis, right? So if you get one mutation that increases your proliferation, the cancer is not quite aggressive, but if you get a second hit, then you become even, you start proliferating faster, and then you get a third hit, and suddenly you can metastasize. It's kind of a similar concept. So perhaps one hit is just not sufficient to give enough kind of proliferation signal to the cells in the tubules. But if you get that second hit, then the cell is out of whack.
Okay, got it. Thank you.
Okay, fine.
I texted you. I was running late. I was like, I'm on the train. No worries. So what's going on?
Probably start in a couple of minutes.
Yeah, Tom was like, just give them 5 minutes for a break. Hopefully, my graphics will be okay today.
Oh, yeah. Why don't you test it just...
You have a question? Hey, good morning, everyone. Can you hear me? Hey, good morning. Let's start. This way we don't run late. Can you hear me? No? Can you hear me? Is that better? Okay, let's start so this way we don't run late. So along the theme of calcium and phosphate metabolism, now we're going to talk about something else that we do in nephrology, and that's management of something called nephrolithiasis or kidney stones. Dr. Curley just told me that you had a lecture recently from one of the urologists on imaging, and you discussed a little bit about post-obstructive AKI and stones as a cause of that. Yes? It's a little hard to hear me. Is that better if I just stay over here? Yeah, okay, thank you. Is there an AV guy in the back who can is there a way to increase the volume? I'll do my best to talk loud, but if you can't hear me, just raise your hand again and let me know, and I'll talk a little bit louder, okay? And I'll try and stay close to the microphone. So today our learning objectives are to discuss some of the epidemiology behind nephrolithiasis, genetic risk factors for stone disorders, review some of the pathogenesis and mechanisms of stone formation, and then diagnosis and management of kidney stones and what we do in our clinic. This is really just supposed to be a fun lecture. It's a little bit, sort of non-traditional in terms of what the kidney does. Given that we're kind of running late, any questions I can address either via email or after the lecture. So here are some nice stone facts. So kidney stone prevalence is pretty common. About 12% of the U.S. population will have a kidney stone during their lifetime, and it tends to follow a gender race predilection, so white men more common than white women, black women, and then least common in black men. And the estimated cost of kidney stones per year is actually quite substantial. Important to remember in an era of cost cutting. So we figure about $2 billion per year, and then office visits are quite high. And as you can see here, although these data are old, they do demonstrate that the trend over time is that office visits for nephrolithiasis is increasing, and between 92 and 2000, and it's a 10-year period, the number of office visits did double, and we continue to see an increase in the number of office visits over time. We worry about stone disease we worry about stone disease not just because they're uncomfortable for the patient and they cause substantial, or they can cause a substantial renal morbidity, but they're also a marker of cardiovascular risk. And in fact, recent epidemiologic data does demonstrate that patients who have had a history of a stone, or what we call stone formers, have a 31% increased risk of myocardial infarction. So it not just as a marker of something abnormal going on with calcium and phosphate metabolism, but along the lines of what we discussed with CKD and MBD, it's also a marker of your risk of having a bad cardiovascular event. Concomitant with the increase in office visits that we've seen over the past several decades, we're seeing that the lifetime prevalence of stone disease is also increasing. And this is important for the epidemiology of nephrolithiasis, which we'll review a little bit in the next slide. But over the past 40 years, we've seen that the prevalence of nephrolithiasis has more than tripled in the U.S. population. Now, there are reasons for this that go beyond just basic genetics, and it's linked to warming of the climate. And when we see, or when we extrapolate, or when we look at the prevalence of renal stones over the course of a year, and we divide that year into the 4 seasons, there is definitely an increase in kidney stones in the warmer months, which will make sense to you when we review the pathophysiology of nephrolithiasis. And then finally, when we look at the map of our country, we can see that there seems to be a stone belt, and that stone belt is located basically in hotter areas of the country. So the stone belt typically is in the south, southwest, southeast, and as the climate is warming, the borders of that stone belt will move farther north, and we can see that it's projected that by the end of this current century, that we will this area actually will be part of that geographic location. Okay. And there's also another fun stone fact. You know, as you know, the moon controls the tides. The moon tends to also control symptoms of nephrolithiasis. And when we look at the lunar cycle, there seems to be more admissions into emergency rooms during the full moon. I mean, one can postulate why that's happening, but I'm gonna just not give my own opinion, and you can think about that on your own. So moving on then to the kinds of stones that we see in the office. The most common stones that we see contain calcium. And up to 80% of stones are a combination of calcium plus calcium oxalate or calcium phosphate, and these can be due to various risk factors such as hypercalciuria, high levels of uric acid in the urine, low urine volume, a low urine citrate, and we'll discuss what the importance of citrate is later on during this talk. Next most common stone is a uric acid stone, up to 10 to 15%. This may be due to having some genetic disorders that result in low urinary pH, or medical disorders that result in low urinary pH, such as the metabolic syndrome. Less commonly, there are stones called struvite stones, or these are a combination of magnesium, ammonium, and phosphate. These are typically due to having chronic urinary tract infections with specific bacteria. And then very, very uncommon, mostly seen in children. So for those of you who are going into the world of pediatrics, you may encounter this more commonly. We do not see this very much in adult medicine, but cystine stones, and then of course we can never forget the fact that certain medications may result in stone disorders or result in kidney stone formation. Indinavir was a very old protease inhibitor that was used to treat HIV. That medication is now out of favor because it resulted in a very severe form of nephrolithiasis that resulted in complete kidney failure. Bactrim, which is a commonly used antibiotic, is known to form crystals in stones. And then allopurinol, interestingly enough, which is a medication that we use to treat hyperuricosuriasia, or high uric acid levels, can also crystallize and form stones on its own, independently of uric acid. So these are the main categories of stones that we see. So take-home message from this slide, remember, calcium is always the most common and what we think of first, and then we move down our list. What is the basic pathogenesis of stone formation? And this is actually goes back to your basic physical chemistry. And basically, it has to do with the amount of ion that's present in the urine. Can you hear me if I move away from the microphone? Okay. It's basically the amount of ion that's present in the urine, and then how concentrated the urine is, which then is also dependent upon the volume of urine. Okay. So the urine is always supersaturated with ion. Okay. And because it is supersaturated, ions can touch and they can form a little crystal or a nidus, and that little crystal can grow. But the beauty of the kidney is that it knows this, so it also secretes into the urinary space things that inhibit stone formation. So stone promoters would be things that may promote stone formation, more typically low urine volume. But then these stone inhibitors are special proteins and special small molecules that actually inhibit the formation of a nidus. And in renal stone formation, something goes wrong here, and then that can happen. So this is just a very large image of a calcium oxalate stone. And as you can imagine, once this thing hits the wall of your ureter, that looks like it's going to cause you a lot of pain. So let's then start with the basic pathophysiology of urinary stone formation. So let's start with hypercalciuria. So think about things that, what may cause hypercalciuria. We reviewed this a little, potential etiologies, last time that I gave a talk to you on CKD, MBD. So it could be anything that can result in high levels of serum calcium. Remember, you're going to filter calcium in the glomerulus. So if you have high serum calcium, you can have high urinary calcium. So the common things are the things that will mobilize our biggest reservoir of calcium. And what's our biggest reservoir of calcium? Bone, 99%. So things that may increase bone resorption would be hyperparathyroidism. We didn't really talk about primary hyperpara that much in my last lectures. We get more of that endocrinology. But the PT, remember that parathyroid hormone can stimulate osteoclasts to resorb bone and then release calcium into the serum. Hyperthyroidism also, you'll learn more about that in endocrinology, but basically high levels of thyroid hormone can also result in hypercatabolic states that can increase bone resorption. Cancers definitely can cause hypercalcemia and stone formation, and renal tubular acidosis. So remember that renal RTAs cause you to be more acidic. And one thing that I didn't mention last time is that, well, you should know this, what also is the biggest buffer in the body? Bone. So when we're acidotic, that stimulates osteoclasts to resorb bone in an effort to release bicarbonate from bone, and at that same time, it also releases calcium. And then there are medications that can cause hypercalcemia and thus hypercalciuria. For instance, corticosteroids, prednisone, can increase bone resorption through the same mechanism of increased osteoclast function. You'll learn more about the pharmacology of this and bone in your endocrine lectures. Remember now, what's the next thing that can cause high levels of serum calcium? High levels of vitamin D. And if we overdose ourselves in vitamin D, remember that the pathophysiology of this is that vitamin D activates the gut to absorb more calcium. So if we overdose on D3, so if you decide that because you think that, the lay press is correct and that we should be eating a ton of D3, and you go to Duane Reade and you buy a 10,000 unit tablet and you take it every day, you're going to make yourself have high levels of vitamin D, and you're going to become hypercalcemic, and you may cause yourself to have kidney stones. So both levels of parent vitamin D, so D25, if you overdose on active D, for instance, if you're giving a patient of yours calcitriol for some reason and you give them too much, you will induce hypercalciuria. And then there are inflammatory conditions that also result in hypercalcemia. Why is that? So these inflammatory conditions typically result in high levels of vitamin D because macrophages also contain 1-alpha hydroxylase. So if you have sarcoid, if you have lymphoma, or even tuberculosis, that can result in a giant cell reaction. They make vitamin D. So they can result in hypercalcemia and hypercalciuria. And then finally, there's a catch-all category for those patients who we can't explain why they have hypercalciuria, and we call this idiopathic hypercalciuria. Typically, it's due to something going on in the gut. Maybe they're absorbing too much calcium. Maybe they have increased bone turnover for some unknown reason that you can't explain, or there are even some renal calcium leak syndromes, which basically are for some reason the calcium channels in the kidney aren't working correctly and they're not reabsorbing calcium very much. Typically, this has been linked genetically to defects in the calcium sensing receptor. We won't discuss that now since we really don't know what's going on with this, but this is just for your information. Okay. So calcium oxalate stones. Remember, most common stone, up to 80%, 70 to 80%. We like to look at urine in nephrology. Urine is fun to look at. It actually is a window into what can be going on in the body. And in terms of kidney stones, when we take a look at urine under the microscope, did you guys get a urine lab? No? Okay. So what we do is we take urine from someone and we spin it down, and then we take the supernatant and then we put it on a slide dish, and then we look at it under the microscope. I encourage all of you to take a renal elective because when you do, you'll spin down urine, and it's actually fun. And when we have a stone patient, what we see is that under the microscope, there's this envelope appearance to these kinds of stones. So they look like these things over here. Very characteristic, classic. You have a patient with renal colic or renal pain. You think that they have a stone, check their urine. If you see that, that's diagnostic. If you don't see it, it's not diagnostic. It doesn't mean anything. So it has a very low sensitivity. So normally, we absorb about 10% of the oxalate in our diet, and then the rest is bound to calcium and passes out in the stool. Remember this. This is very important, because when it comes to therapeutics, we're going to talk a little bit about this reaction in the intestine. Okay. Risk factors for calcium oxalate stone formation, as we just discussed in detail, hypercalciuria. We also mentioned high levels of urinary uric acid. And the reason why, maybe you can guess, why do you think high levels of urate in the urine might be a risk factor for calcium stones? Remember, molecules in the urine, if they're close together, they'll bind to each other. So what happens is that if you have high levels of uric acid, it'll bind to the calcium, and that can act as a nidus. And then that will just attract more crystals from forming around it. So you'll get a calcium oxalate stone. Okay. Hypocitrate-uria. So citrate is a stone inhibitor. And if you have low levels of urinary citrate for some reason, that will promote stone formation, even in the presence of normal urine volume. Hyperoxalate-uria, same concept as high levels of urinary uric acid. Once again, low urine volume. And then there are some medical conditions. You guys have had GI already? No. Okay. So in gastroenterology, there are some inflammatory bowel conditions that result in excess oxalate absorption in the intestine. So that can result in hyperoxalate levels in both the serum and in the urine. So that can be a risk factor. Gastric bypass also results in excess oxalate absorption. Obesity and gout. So this is part of that metabolic syndrome. And metabolic syndrome is associated with high levels of uric acid in the serum and in the urine. And then there are some genetic disorders. There's a liver disorder that's associated with excess production of oxalate. Okay. So these are the main risk factors for calcium oxalate stones. Calcium phosphate. Second most common stone type within the calcium category. So when we say calcium stones are the most common, we mean calcium oxalate and calcium phosphate. By far, calcium oxalate stones are the most common type of calcium stone. The second most common type of calcium stone in this bin is going to be a calcium phosphate stone. Okay. When we look at the urine under the microscope, they have this very pretty appearance looking like a coffin lid. And risk factors are much more condensed for calcium phosphate stones, typically hypercalciuria, of course. Interestingly, there's an association between having a more basic urine pH in calcium phosphate stones that's based on the pKa of the ion. And then there are some genetic disorders of the kidney, in particular something called medullary sponge kidney, which basically has a distal tubular defect that's associated with it, and that alters urinary pH, and they're predisposed to calcium phosphate stones. Okay. And what's interesting about these stones are that calcium oxalate stones tend to be a little bit softer, calcium phosphate stones tend to be a little bit harder, and they're much harder to get rid of. They're called brushate stones, and these are much more pathologic if they occur. And another interesting fact about calcium phosphate stones are that they crystallize and they form the same sort of matrix and material as what we have in bone. So hydroxyapatite is the bone mineral, and these kinds of stones form the same kinds of crystal patterns as bone, as what we have in our bones and in our teeth. So moving on down the list of stones, uric acid stones, second most common catch-all category of stones. Up to 15%. And when we look at them under the microscope, they have a very pretty diamond-shaped appearance. Risk factors are having acidic urine, things that make you have high levels of uric acid in your serum, gout, metabolic syndrome, cancers. Cancers result in high cell turnover and thus high levels of serum uric acid. And what's different with uric acid stones are that they typically don't contain too much calcium, but sometimes they do. So when you're imaging, and we'll discuss this a little bit later, when you're imaging these kinds of stones, If you just get a plain film, you may not see them because they tend to be radiolucent. They're detectable by renal ultrasound and also by CAT scan. And the reason why by CAT scan is that sometimes they do contain a little bit of calcium, and the higher resolution of a CT is able to pick up that calcium or detect that calcium, which a plain film can't do. Okay. So these are struvite stones. These are, I'm not sure if you discussed this kind of a stone in your urology lecture, but these are nasty stones. These stones basically grow to be so big that they take up the whole entire space of the urinary pelvis. And when patients have these stones, they can be catastrophic because they can't be removed by typical surgical techniques, and sometimes you need to go in, slice the kidney, remove the kidney, slice the kidney open, take the stone out. So here you see an image from somebody who was unfortunate enough to have a huge stone and require a nephrectomy. And when the kidney was sliced, you can see the struvite stone right here. Okay. So we call these stones staghorn stones. That's another name for them, which you may hear during your career. And that just is in reference to the way we used to diagnose these stones, which was by plain film. And on the plain film, you can see that the stone has this sort of staghorn appearance. So they got the name staghorn stones. Classically, these stones are made of a composite of magnesium and ammonium and phosphate plus calcium carbonate. And the risk factors for these stones are pretty defined, and it's when we're infected or our urinary tract is infected by bacteria that split urea. And there are specific bacteria, Proteus, Haemophilus, Klebsiella, Uroplasma urolyticum, which are classically associated with these stones. So you can imagine that risk factors for staghorn calculi would be in those patients who have a risk for having chronic urinary tract infection. So who are those patients? So these are your patients who you'll see who may have neurologic disorders, patients who have spinal cord injury, have poor bladder function, urine sits in the bladder for a long time, and when urine sits in the bladder for a long time, that's a risk factor for having an infection. So thus, once again, patients also with chronic urinary tract obstruction. So your little old men that have benign prostatic hypertrophy, who can't pee so well, they may be at risk. And then women who more commonly have UTIs than men do. So moving on to the more rarer types of stones, we have cystine stones. So remember, once again, these become more important in pediatric practices than in adult practices. These are due to autosomal recessive defects in tubular transporters of dibasic amino acids. And unfortunately, when there's too much of these amino acids in the urine, they attract each other and they form these crystals. And typically, they're these hexagonal type of crystal formation. Cysteine in particular is insoluble in acidic urine. And we image them, or we can detect them in kids by either CT or ultrasound, once again, because typically they do contain a little bit of calcium. And these are another type that if they're not detected early enough, because cysteine is completely insoluble, they'll grow and grow and grow, and you can develop a staghorn. So you want to detect these early, so this way you can prevent your child from moving on to end-stage disease. So that's it with the kinds of stones and their risk factors and what they look like under the microscope. And let's move on to stone inhibitors. So what are these things? So they were first thought to be present in the urine in the 50s, and it was due, and they were hypothesized or postulated to exist due to the inability of urine to inhibit cartilage calcification in rats. I don't know why they were adding urine to rat bones, but it's just an interesting side. What are they? So typically, they're groups of negatively charged molecules, and they inhibit crystal nucleation, and then they also prevent crystal growth. So they adhere, if there's a nidus that forms, they adhere to the surface, and they prevent further ions from coming in and making that crystal grow. So they adsorb under the surface, and they interfere with lattice formation. That's the basic science behind it. Okay. And there are a growing number of stone inhibitors that are identified every year. This list is from a couple of years ago. There's no need to memorize this list because it's, once again, it keeps on growing, and in many cases we don't really understand how exactly these guys prevent stone formation. But remember that they come in two flavors: take-home message, ionic inhibitors, and macromolecular inhibitors. As you can see here, under the ionic category, it could just be magnesium citrate versus other kinds of molecules. And then for the larger inhibitors, these are typically protein or proteinaceous inhibitors. Tam-Horsfall protein, I'm not sure if you learned about that during this course, but THP is the most abundant protein in the urine, and that has been thought to inhibit stone formation, although we're not so sure about it. There's something called nephrocalcin, which is another protein that's in the urine in high concentration that tends to inhibit stone formation. And then once again, as I mentioned, there are new arrivals. So this list keeps on growing. Okay. How do we diagnose stones? Okay. So the clinical presentation of a kidney stone is classic, and somebody's going to come in and say, "Doc, my kidney hurts," and they're going to point to their back. Or they may not point to their back, and they may actually say, "I have severe groin pain," or "There's this really weird pain that's radiating, dull, sharp, or something pain radiating down to my groin." You may also find that on exam that they have tenderness when you palpate their back. That's CVA tenderness. You may look under the microscope and you may see blood in the urine. You may see hematuria. Okay, if you see hematuria in the context of having a patient with clinical symptoms, that's pretty diagnostic. Okay. If you don't see blood in the urine, what does it mean? Nothing. So remember, poor sensitivity. Less commonly, patients may have a silent obstruction, and actually, I'll take that back, less often. Actually, it seems that we're seeing now a lot of silent obstruction in our patients. You may have a patient who has a UTI that you just can't get rid of. You treated this thing over and over again, but it keeps coming back. That should sort of light a bulb in your head and say maybe this person has a stone that's infected, because bacteria, they like to get into the pores of the stone and live there, and when you treat them with an antibiotic, the antibiotic sometimes can't penetrate deep down into the stone, so they can have a persistent UTI. And then some patients may just have painless hematuria. So although I showed you that image of a calcium oxalate stone that looked pretty scary and nasty, sometimes, and it looks like it should be painful, sometimes that's not the case, and sometimes these patients have no pain, but they do have unexplained hematuria, and it's part of our diagnostic evaluation. So if someone does come to you and they say, "I have flank pain," you need to always think about things that maybe it's not a stone, okay? And although I just said to you, "Doc, my kidney hurts," kidneys don't hurt. Remember, so the kidney inside doesn't have any nerves. All the nerves are in the capsule. So if somebody has kidney pain, it probably means something else is going on, okay? And the pain that one gets from a kidney stone is when actually it's from the hollow viscus extending, okay? So there's also a number of things that you need to think about when you're evaluating your patients for renal colic or for kidney pain. And think musculoskeletal, think zoster, think GI etiologies, think something going on within the kidney itself, like something that may expand the capsule, and then of course always think about obstruction from other causes. So what is the sensitivity and specificity of these tests that we use? I mentioned that we like to look at urine because it's fun, but how useful is it? So when we look at crystals and hematuria in terms of how they inform our diagnostic evaluation, crystals can be present in healthy individuals too. If I just, before I came here, I went to the gym, got on the treadmill, probably a little dehydrated. If you check my urine now, I may have some crystals there, but it's meaningless because I don't have kidney stones. Okay. So sensitivity and specificity of, what sensitivity and specificity is, right? You know how to interpret those terms. Low for crystals. How about microhematuria? Kind of, okay. Kind of a range. I mean, if you think that you want to have something in the range of 80%, then sensitivity may be okay, specificity not so great for microhematuria. So although we like to take a look at the urine for stones, for crystals and for blood, we really rely on other tests to make our diagnosis. And we rely really on imaging. And Imaging comes in a couple of different types. We can do either a plain film, so a KUB, kidney, ureter, bladder. It just refers to the image that we're taking a picture of. We do ultrasound, and we can do CAT scan. Okay. So for a KUB, we need to rely on the fact that renal stones contain calcium. And here's your stone here, and that's a big stone. So we rely on the fact that some of these stones have calcium. If the stones don't have calcium, then we're going to miss it. So a KUB really is sort of a screen. It's something just to know about. We never really use it. And we never use it because it requires that the stones are big, that they contain calcium. Maybe it helps us with stone localization and getting a diameter, sort of a rough estimate. But other than that, it's really not that great of a test. So we tend to prefer other tests as our initial imaging tool. How about renal ultrasound? Now, renal ultrasound is very nice because it can pick up both stones that do and do not contain calcium. So it's a really nice first kind of test that we can use to detect for stones. It can also tell us whether or not the kidney is obstructed, so you can pick up hydroureter, hydronephrosis. It's really what the test that we use as the primary test in pregnant women. You don't want to expose the fetus to any radiation. And in children. Remember that we're worried about, remember all these tests, X-ray, CT scans, expose our patients to radiation, and over a lifetime, we want to try and limit how much radiation they're exposed to. So this really is a great test for children also. High specificity, okay sensitivity. However, one of the main limitations of this is that it really is poor at picking up stones that are small. So what's small? So we're going to discuss small in a moment and why that's small. But 5 millimeters, less than 5 mm is considered to be small. So once again, similar to the KUB, renal ultrasound is really good for picking up larger stones. We'll miss the small ones. The best test is a helical non-contrast CT. Okay? And the reason why we say non-contrast is that once you give somebody contrast, then you lose the ability to differentiate calcium from contrast. Okay? So this is our study of choice. Here's your stone right there. And it has very high sensitivity, very high specificity. It's fast, takes only like a few minutes. It can visualize stones that are not primarily calcium, such as uric acid stones. And what's great about the CT scan is that it can help you with your differential. So basically, as I mentioned before, you need to think of other things that may be causing pain in the back. And this can pick up abnormalities of the urinary tract. It can pick up abnormalities going on in your abdomen. So it really helps inform your full and complete differential. Okay, let's move on to management. And management of renal stones is actually pretty simple, and it's fun, because it's the one thing that you can do in medicine or in nephrology where you can just stop the problem from happening. And because the pain is so severe that these patients experience, they're so grateful when you stop them from having stones. And most patients will tell you that, and this is coming from my female patients, that having a kidney stone is worse than childbirth. So if the pain is that severe, you can imagine how grateful they are when they stop making stones, and then how dedicated they are to their own health care because they don't want to go through that again. So stone size. What's a small stone? What's a big stone? And why do we care? So we typically define small stones as less than, here, really less than 5, but here in this figure they're going to say 6 mm. And why is that? And that's because the mean number of days that it requires to pass a stone increases with increasing stone size, and then the need, of course, obviously, the need for an intervention increases as the stone size gets bigger. So when patients have a large stone, if I have a patient with a stone that's 7 millimeters and they're obstructed, I know that that thing is not going to pass by itself, so I need to call up my urology colleague and say, help me and let's get rid of the stone. And there are various methodologies by which the urologist can do that. Small stones, I don't worry too much about. I deal with pain management, and the stone typically passes by itself. Okay. So based on stone size, And based on metabolic profiles, we can devise treatments then to get rid of stones that are present and to prevent the stones from occurring again. And as we go back to think about what our risk factors are for stone formation, we basically pick off each potential risk factor, and then we determine whether or not our patient has that risk factor, and then we base our management on their risk factor analysis. The next thing that we do when we stratify our patients for management is we think about, well, is this the first time that they're having a stone, and is this going to be a single event, or is this recurrent stones, and are they at high risk for future events? Okay. So the first time that somebody comes to see us, we typically just do a very limited evaluation, okay, and that limited evaluation is actually pretty comprehensive. So we do a risk factor assessment. We look at their occupation and environment. We ask them questions. Are you a construction worker? Are you working in the summertime outdoors? Because you're going to be sweating, you need to drink water, if that's the case. Family history. There's a very strong genetic component to renal stone formation. So if there's a family history of renal stones, we tend to worry about it a little bit more. In particular, if that family history includes people going on to end-stage disease. We evaluate their diet, and we determine protein content, how much sodium they're eating, how much calcium, oxalate-containing materials they're eating, how much do they drink during the day. And then we do a very thorough medication assessment. We evaluate them for medications that we associate with risk of stones, so triamterene, blood pressure medications, and Indinavir, not really on the list anymore, Bactrim, and then carbonic anhydrase inhibitors. We do a very focused laboratory evaluation. So we think about things that may actually increase their risk of stone formation. We check their kidney function, of course, because that's important for us to know that. If you have a stone patient with CKD, we worry more about that than somebody who has normal kidney function. Check their bicarb for the level of acid in the blood. Of course, calcium phosphate. And then we do a very basic hormone profile of just parathyroid hormone. Once again, we look at the urine, we look at urine pH, and then we check for a UTI with the urine culture. Despite whether or not a patient has a first stone, if they're a specific kind of patient, they automatically get referred to a stone clinic for a more further evaluation, and this is because we worry about their risk of progressive renal failure. So kids, if you have a kid with a stone that's not normal, they need to be seen by somebody who's a specialist, because you don't want a kid to have end-stage disease. Anybody with one kidney, okay, if you have one kidney, you worry more about progression to renal failure, so they get sent to a stone clinic. Anybody with a staghorn, anybody with abnormal kidney function, and anybody with a renal tubular acidosis. These are the high-risk people. That's why they get sent off to stone clinic, even for a first-time event. So then, for recurrent stone formers or for high-risk people, we up the ante. And we don't just look at a single urine analysis, but we get a 24-hour urine collection. And the urine collections that we get are processed by special laboratories that deal with this issue, and they give us very fine, detailed information on urinary levels of calcium, oxalate, citrate, uric acid, pH, blah, 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 all of the main things that cause stones. And then, once again, we'll repeat urine cultures if patients have staghorn calculi, because they typically are associated with infections. They want to make sure that we detect that infection, even if the first urine culture was negative. What is this? This is the stone risk profile that we get from a 24-hour urine collection from Stone Clinic. So just when you eyeball this, okay, I don't want you to like look at this in too much detail, but to eyeball, red is bad, blue is good, obviously. They assess factors that are metabolic, environmental, and then relative supersaturation. Remember, supersaturation is an important component of stone formation. And then, based on this profile, then they give you very nice readouts of what are some potential problems. Now, given that this is just a urinary profile and not an analysis of the stone, this is a little bit more limited in terms of your diagnosis. It does help with management, though. The best thing that you can do is to get the stone, because once you get the stone, you can look at the content, and it gives you a better idea of what's going on. But unfortunately, getting the stone is not always easy to do. I mean, you would think that it would be, but sometimes it's not. And most patients don't catch their stone. You can give them like a hat to strain the urine with, but sometimes it doesn't work. In particular, if you have a person who gets up at like 2 in the morning and they pass their stone, they're not going to remember to strain the urine at 2 in the morning. So as an example here, what this says, so this person here has high levels of, low levels of citrate. Sodium is high, so urinary sodium is high. Let's see, sulfate's high, phosphate's high, but also is high. So sodium urate is high. So based on this, and urate is high here too. So based on this, what they're saying is that the patient has too much uric acid in the urine, not enough stone inhibitor, so not enough citrate, and the urinary sodium is too high. And what they found was that when they evaluated something called the supersaturation index, which is a measure of the ability of the urine, or the supersaturation of the urine, obviously, there's too much monosodium urate. So the suspected problem, and remember they're saying suspected here because they haven't caught the stones, just a urine analysis, is that this patient has uric acid nephrolithiasis. And they give some recommendations. Maybe the person's eating too much animal protein. Animal protein is associated with high levels of uric acid. And then you would also want to evaluate this patient for metabolic syndrome. Maybe they're obese or something. Maybe they're on a medication that causes high uric acid. Maybe they have a malignancy. So then treatment. So then our treatment options then can be to decrease the ionic concentration of whatever is causing the stone after you've done your analysis. You can alter the urinary characteristics, or you can alter the urinary supersaturation. Okay. So if your patient had high levels of urinary calcium, you could decrease urine calcium levels. How do you do that? Well, if they're not hyperparathyroid, okay, you can give them a medication called hydrochlorothiazide, which you all know as a blood pressure medication. But hydrochlorothiazide results in reabsorption of calcium from the urinary space into the bloodstream. So you can decrease urinary calcium levels by that way. You can do, for patients with calcium oxalate stones, you can restrict their consumption of oxalate. And the New York State Department of Health has a wonderful webpage on foods that contain oxalate. And you can either direct them to that website, or you can just tell them, stay away from things like green leafy vegetables, chocolate, nuts. So you can do a lot of things that can actually help them manage their disease with just simple dietary measures. If your patient has uric acid, like in the example that we just showed you, then you can restrict their consumption of foods that contain purines, or if that doesn't work, you can put them on a medication like allopurinol, which will definitely decrease urinary uric acid levels. For altering urinary characteristics, we can think about what's wrong with the urine. So like for instance, in patients with primary hyperparathyroidism, you can send them for parathyroidectomy. That will definitely decrease their urinary calcium levels. Patients that have distal tubular RTAs, you can begin them on sodium bicarbonate therapy, and that will change the urinary characteristics and make them be less predisposed to forming calcium phosphate stones. And then with supersaturation, you can either make them produce a more dilute urine, so make them drink more water, or you can give them medications that are that can alter the supersaturation, such as citrate, and that's called Urosit K. Okay. So is there any evidence for this? And remember, it's always important for us to know the evidence behind the interventions that we're asking. And there are some clinical trials that have looked at the utility of water and also of citrate in terms of how they can alter our predisposition to stone formation. So one of the most important things that you can ever tell your patient with a stone is to drink water. Just drink. That's the primary intervention that we all focus on. And there's a very nice study from about 2 decades ago that looked at patients who were on 2 types of water regimens. The first group was told to drink about 1 liter a day. The second group was told to drink a little over 2 liters a day. And when you look at the incidence rates of stone formation over a period of 5 years, those patients who drank more water had a significant reduction in their stone risk over 5 years. That really is the primary thing that we do with these patients, and it's a cheap, effective way to prevent them from from having stones. And that benefit is present when you look at the curves. So this is called the Kaplan-Meier curve. When you look at the curves and when they splay, meaning when do they separate within the first couple of months of telling them to drink more. So the benefit of water is immediate. Okay. How about their diet? And do you think that in a person who has calcium oxalate stones, that they should be on a low calcium diet or a not low calcium diet? I mean, I would think, before this data came out, that they should be on a lower calcium diet. But remember what I told you, that 10% of the dietary oxalate is absorbed, and the other 90% is bound to calcium and then passes in the stool. So if you put these patients on a low calcium diet, their stone risk actually increases because they're absorbing more oxalate. So there was a nice clinical trial that looked at this dietary intervention about in 2002, and what they showed was that patients who were randomized to a low calcium diet actually had a higher risk of stone formation over time. So the two primary things that we do. So for all stones, we say water. For calcium oxalate stones, we say eat a normal calcium diet. We wouldn't say eat a high calcium diet, because they'll probably absorb more calcium and get hypercalcemic or hypercalciuric, and that will probably increase their stone risk. But we don't tell them to limit their calcium intake to anything substantially low. Urinary citrate. So urinary citrate is very nice for all stones, whether or not it's calcium or non-calcium containing. And what these figures here demonstrate is that when we administer calcium to patients, it really results in a reduction in ion formation. So here you have calcium on the Y, you have urinary citrate on the X. Here you have constant rates for stone formation. Here you have total calcium. Sorry, I can't see, sir. Too small. Yeah, here you have total calcium, or total calcium, but for two different concentrations. And basically what this is saying to you is that when you increase levels of urinary citrate, your ion formation decreases. Okay, so it's just a nice demonstration that when we give our patients a medication like Urocit, we are going to inhibit their ability to make stones. And how about urinary pH? And remember, there are really a couple of kinds of stones that this is a risk factor for: calcium phosphate stones, uric acid stones. For uric acid stones, low urine pH is a problem. So patients who maybe who are overweight, metabolic syndrome, or have high levels of serum uric acid, when the urinary pH is in this range over here, that's when they're at risk for stone formation. So we can give them alkali bicarb. It raises the urine pH. Uric acid doesn't crystallize, and their stone risk decreases. Okay. And then for kids who may have cystine stones, there's certain drugs that we can give to them that may help, in particular captopril, which is an ACE inhibitor. So once again, another non-hypertension use of a hypertension drug. And captopril can bind to cysteine, and the complexes are very soluble, and that can help that particular patient from having ongoing cystine stone formation. Okay. And I'm going to rush through this because we have to get you to a small group. But in terms of surgical management, we base our decision on stone size. So larger stones typically go to surgery, in particular if they're infected or a patient have a ton of pain and they have a lot of other symptoms such as nausea and vomiting. We have a couple of methodologies that we use to intervene urologically for large kidney stones, something called extracorporeal shockwave lithotripsy, ureteroscopic removal, percutaneous nephrolithotomy, and then there's always open surgery for struvite stones. So shockwave lithotripsy really is basically applying a shockwave force to the external body wall, sort of above the kidney, or, in the back where the kidney is, and localized to where the stone is. And basically these continual shock waves just get pummeled through your body. You are asleep for this. You're not awake because it can be painful. It's better for stones, once again, that are proximal. Proximal meaning closer to the kidney rather than distal, meaning closer to the bladder. It's better for smaller stones because smaller stones are easier to pulverize externally. And we don't want to do this procedure in patients that have bleeding tendencies. Of course, patients who are pregnant, this would be an absolute contraindication. Uncontrolled hypertension is another contraindication because when we induce, because this does induce some tissue damage to the kidney. So if you have hypertension that's uncontrolled, this may